Hello, thanks for having me. So I guess I'll be interested to hear about your thoughts, I guess, at the end of the approach that we took. I'm assuming it's quite different and less technical and less structured, I assume, than some things that you work on or that you'd expect to hear. So I'll be interested to hear that. So a little bit about SH24. It stands for Sexual Health 24 hours a day. We started in 2012 as a concept, and I joined the team early 2014, so I've been there 3 years now. We are a community interest company, so any profit that we might one day make, we reinvest in the local area or the local charities that have supported us to start or reinvest in the team, things like that. So these are the kind of starting partners. So Kings and Guys, we have some really strong clinical relationships with, and we have directors at SH24 that are clinicians and consultants there. And then Southwark and Lambeth public health teams within the council, that's where it all began. So I'll just make sure I've said what I needed to do in terms of an intro. So Gillian is our managing director, and she was leading the public health team at Southwark and Lambeth until autumn. And Paula still currently is a consultant at King's in sexual health. So they kind of had this vision. They were really frustrated by the sexual health landscape, essentially, and wanted to make sexual health services easier and faster for people to access. So they kind of batted around what that meant and tried to map out what digitising those services would be. And they created a bid, and they went to Guys at St Thomas's, who said, absolutely wonderful, but you two can't do it. You haven't got the right knowledge, you haven't got the right skills, so go out and find some people to work with you on it. So, so then they went to Design Council, who supported them to do a bit of scoping for what the project could be, to rewrite the bid and to build some structure into the development of the technical side of things. And so at the time, SH24 was a kind of charitably funded concept, and now we're a commissionable service. So I'll kind of talk through how that journey went. Hello, by the way. And we're multidisciplinary. I'm not sure if I spelled that right because I can't really spell. But that's a really, really important aspect of our team. So within, when we're in a room, there's people with decades of sexual health experience, council commissioning experience, design and technical background, and all of that coming together really openly has been, I think, the key to SH24's success. So here we are. These are my 2 developers and myself winning the awards last year. So that's another part of the intro, but you've already heard that. So this is what I'd like to talk and share with you. So what was the problem? Why SH24? What we saw the opportunity being. A bit about our approach, where we're at, and some just sharing some how we've optimised the service. And then we can chat after that. So the problem. Southwark and Lambeth was generating headlines and data like this for quite a long time, which again is one of the reasons why Gillian at the council was so keen to do something about it. She didn't want to be the head of a public health department with the worst sexual health in Europe. This is Camberwell Clinic. That's classic. Every day people queue to get in. The access is really terrible. The opening hours are really difficult to interpret. And people get fed up and walk away, and that could mean all sorts for whoever they encounter next. This is Burrell Street. That's another service in Southwark. There's another queue, which makes it really easy to find people to talk to, which is good. I spent many hours in clinics. This is a photo of opening hours. It's not a very good one, but new clinic opening times. Who knows when to turn up? Because some are appointment only. How do I book an appointment? I don't know. It's terrible. And that's probably quite a good one because that's on the outside. So barriers to access, just to kind of run through again why there's an issue around access to sexual health services. So there's quite an obvious stigma, particularly for younger people. That's something that, you know, they don't want to run into people that they might have seen the night before. Finding a service, like that poster that we've just seen, it's really hard to find a service and then know when to go to it. Services are closing all over the place. Loads of people take half a day off work just to attend a clinic, to risk not even getting an appointment due to the fact that they're walk-in clinics. The waiting times are really long, which again helped me with my research. And waiting for results takes ages, which then possibly means you've got a 2-week period where you could be spreading an infection or not being well yourself. Private services are extremely expensive and make people overly anxious about infections that you can't treat and don't really need to know about. So there's an interesting education thing around that. Also, funding. As with lots of public services, there's a huge problem with demand and available cash. Oh, that's to give you all a shout out. Barriers to providing the service. So again, finances. They're just constantly being told to cut. This picture was taken, I think, right at the beginning, so yeah, 4 years ago, and the room looks exactly the same, literally exactly the same, everything. That's still there, that's still, you know, everything. So there's very little kind of change. So change is a really interesting thing to try and introduce to very traditional and culturally stuck situations. There's a lot of fear, so people like her will think, this service is going to take my job, I'm going to be out of a job, and get kind of anxious and defensive around introducing a new service because they think their job's at risk. In terms of commissioning, there's really inflexible, long contracts that services and providers are in. So to introduce a service transformation within a 5-year block contract is actually quite difficult, and you need a really strong-willed person to try and introduce a new way of doing things if a service is already commissioned. And responsibility. So sexual health has kind of been shoved from council to NHS to back and then in between. And so whose responsibility is it to run sexual and reproductive health services? How far do the GPs go in terms of accepting cases or referring them back out? And all of those things is quite a complex map that changes according to what borough you're in and where you're from and how old you are and all of those things. So, what the opportunity is. So, as I said before, so make NHS services easier to access. So, our aims, right from the start, was to improve the sexual health of the population. So, local in brackets. We knew that we needed to start somewhere, start small and create an impact somewhere locally, but that was not the overall aim. We thought that this should be a scalable service that created opportunities to improve the sexual health more widely. And within that, to introduce faster, more efficient services, so rapid treatment and diagnosis, not waiting 2 weeks for a result. And actually some services don't give you a result if you're negative, which is actually really unhelpful for people that are worried and waste a lot of time trying to phone up and find out. Rapid access to contraception, again, very similar issues of trying to find a GP appointment that you can go to without having to take time off work. And the promotion of self-management, so kind of challenging a bit of that stigma that I mentioned. Loads of things now are 24/7 and available online, so why not sexual health? So that was a challenge we kind of set ourselves. And working and kind of exploiting as much local clinical knowledge as we could along the way, and kind of shouting about that a bit as well, not being afraid to be really clinically led. You know, we can be a cool new service, but we have to have a good foundation. And then, yeah, to reduce costs, so to give commissioners and providers a new way of delivering the same or more services, but for less money. So our approach, I kind of say we've got two principles. So one is all about users and people and spending time with them, and the second one being post-it notes. I'm sure you're all fans of post-it notes. We are. But really our main principle for the approach is to develop the minimum, fail fast and fail cheap. So that's, I guess, where us relying on a printer and paper and pens came through quite a lot. So when we went to guys with our bid, we said, this is what we want to achieve, but this is where we'll start. So with a full STI test available to order over the internet. Second to that was a support service. I can talk a bit more about that now. So we, in the bid, when we wrote it, we said telephone support service. We learnt a lot about how people would like to access support, so that isn't necessarily defined as a telephone support service anymore. A basic contraception service and a fuller contraception service, so really pushing what we can achieve in here. So we set ourselves the aim to do, to release an STI service, and we created this multidisciplinary team, again, as I mentioned, and we were really, really lucky to have a network of clinicians to work with. But also developing that, we got a load of developers in a room, which is what you need, I think, when you're trying things out really fast. So that was a bedroom in a townhouse that we borrowed for a few months in the summer of 2013. And this was where it was. Oh, no matter where, no. This is where we were, in Denmark Hill, and that's where the clinic was. 8-minute walk, perfect. So in the morning we could sketch something up, we could take it there, we could go back, we could print it out again, we could go back again, and especially Tuesdays when you're open till 8, there's many trips you can make with iterations along the way, so that was the perfect location for us. So things we did in terms of discovery and design research work for MVP1. We did loads of user journey mapping, so again, all on paper. So we mapped out on A3 sheets lots of different options that people could take at different points, and tried to just ask loads of questions as to, you know, why did you make that choice? What would have influenced you to feel more comfortable making the next step? And just started to map out and challenge a lot of the assumptions we were making about how someone might access or order a STI kit online. We spent lots of time with clinical staff and reception teams, and we kind of made ourselves accountable to those. Not that it was something that they asked us to come present every week, but it was something that we tried to put the effort to do, so that we were constantly kind of validating what we were hearing from clinic users with the people that see them every day, and kind of map what questions users said they would ask to those questions that clinicians said people do really ask, or the things that people do really struggle to understand. Focus groups, so being very aware of when exams are and when half terms are is quite a good thing to do when you're planning focus groups, as we learnt. We did a online survey. We benchmarked and so made loads of fake orders of existing services from different areas of the country, and also from some of the private providers, as I mentioned as well, and just tried to map out the experience of each of those services end to end, from ordering to getting your results. So some of them you have to log on to an online portal to get your results. Some kits come in a huge bag, and it's very non-discreet, and it's lots of different components that when you open it up you're like, okay, you have no idea where to start or what to do. So there's loads of learning to be to have to experience from benchmarking other services. Lots of things we did there. So after all that work, which was a period from February to April, myself and Chris, he can't be here today, I forgot to say that at the beginning, he's my boss, we decided to put a branding tender together. So with all the insight that we've picked up and learnt from the user groups that we've been meeting, put out a tender to help us support to build a brand around the concept, and then a request for proposals for a development team to join us that you saw in the picture. So for the summer, we had a team take us through an agile development process. So that was great. So these are literally as far as our personas got. So they're not beautiful, they're beautifully shareable documents. They are really useful tools for us, and we still use them now. But essentially they're based on the types of people that we met, the types of lies they tell to access services, which is really interesting. So some people pretend to be 14 to be seen earlier in the clinic, because you get fast-tracked if you're 14. So, you know, roll the skirt down and do the top button up and things. All the thoughts around how people are wayfinding themselves through this difficult service. How far people travel to hide their sexuality and to not be heard, not be seen by people that they might know, all that kind of thing. So at the beginning of the discovery phase, we kind of mapped out, on my first day actually, the assumptions we had around how people might access this kind of service. And all that work gave us these answers. So, yes, people do want an online service. They don't want an online account. There was lots of like screwed up faces, like why would I need that? Or why would I want to associate myself with an account that someone else might be able to log into? So that was really interesting, and that linked a lot to our conversation around, is SH24 an app or is it a website? Is it something in between? And definitely the kind of online account app thing seemed less attractive to have, I guess, to identify you back to a sexual health service, again due to the stigma. So that was an interesting insight, but then we didn't want to go, full hog to be like, let's make this as discreet as possible, and so no one would ever know this is a sexual health service. But anyway, yeah, people will complete an online risk assessment. That was so risk assessment is really about what kit do you need, and how do we manage your results when they come back. So are you high risk of contracting a virus, and how might the clinician notify you of that when your result comes back? And that was really acceptable. I mean, it was an expectation, really. It was how we delivered those questions, and we learnt a lot about the language of how you present those questions when you're not face to face with a clinician. So using words like acute doesn't make any sense to anyone that's doing a online form. Use normal language and explain it as much as you can with supporting information. So language was a huge part of our learning there around the risk assessment. People are happy to receive their kit at home. There was quite a bit of discussion around how discreet that service would be. Do I have to be in? Will it fit through my letterbox? And just making sure all those things were ticked off and that they were really clearly communicated. People are confident in doing the test at home. So again, quite a similar thing with, this is too medical for me. I'm not kind of qualified to prick my own finger and provide a blood sample. This isn't for me. And how do we really enable people to feel like this is something for you? This is exactly what it is for. People will return the test by post. So returning samples back to the lab, we've understood that's fine. We provide free return envelopes, so that wasn't a problem. People prefer to receive their results by text, was proved correct, so there were lots of other options we were asking about. People will be prepared to log into an account for more details about their diagnosis and treatment. So here, that was quite a clear no, but in kind of wider conversations, now we do, but at that point, if and when we did provide a contraception service, that would then become quite a useful thing to have a record of. So they were the assumptions, and that's how we kind of defined the user journey that we wanted to start designing. So from that point, I'm not sure if you can see, probably not see that very well, but we created an end-to-end funnel. So each of these post-its kind of is a point at which something could put someone off from using the service and not going any further. And the dots signify we really need to sort this out, otherwise we're going to have big problems. So there's things like landing page, what could stop people from further engaging in the offer. And so we've got things like crack proposition, trust in the provider was a huge thing, so ensuring that we're enabled to associate well with the NHS and be quite clearly a kind of safe and trusted, and all of those things that are associated with with the NHS was a big thing. Not my tone of voice, so we worked hard to not make it feel like a service for young people, because actually it isn't. You have to be over 16. So that was quite a thing for testing the brand, to ensure that we weren't putting people off that were thinking it was too young or inappropriate. So then we've got things like address and contact, and not wanting to be identified and keeping myself discreet, that we just had to work well to buy the right envelopes and print nice clear labels and not label anything with SH24 on the outside. On that as well, we do quite a lot of work when designing the interface between SH24 and the pathology lab, so that when the samples go back to the lab, there's no identifiable information associated to the samples. So how that works is they're all coded with a 32-digit code. So when I send a sample back, the lab knows me only by my code, sends the results back to us associated with that code, and then we associate the code back to the U and get that result to you. So that was an interesting few weeks of making sure we had a code that was big enough for the lab to be able to scan, but was small enough to be acceptable by the user to be on each of their samples. So that was a big thing about discrete, and we're not aware of any other provider that has taken it that far. A lot of them still have to write your name and the date on every single sample that you send back, which obviously it could get picked up at any point in between there and be associated back to you. I'll skip forward. So then we've got this big problem area here, which is doing the blood test or providing a blood sample. So that sample is used to test for HIV and syphilis. So there's things like people are afraid of blood, people are scared of needles. I can't read what that one says. Lack of confidence, getting enough blood, scared of the lancet, is it enough? So all these things are massive blockers, and providing an insufficient sample means that you won't get a result, which is then a massive waste of effort and quite a big frustration for the users, but also for us having to pay for a pathology service that you doesn't go anywhere. So we knew that there was lots of things that we could do there to support users to do it well. So we did a bit of a hack of what we could understand of how many users would have this trouble, what investment do we need to put into fixing that issue, and who do we think we could be persuading with the right amount of reassurance to complete the test. That was based on some Camberwell Clinic data of the amount of people that access their service. So this is the problem. Sorry if you don't like it. You have to fill to the 600 line here to provide enough, which is about 16 drops. And after a while it does become a little bit difficult if you start clotting up on your finger. So we took this problem, if you like, to a hack day in Brixton, which we arranged with the council. So they invited anyone who they wanted to come along to try and design what the kit would look like, how it would be delivered. And this was interesting, because this is an assumption we had made, that everything should be kind of contained separately. So some of the existing kits, as I mentioned, all comes in one, and you're not sure what's what. So to separate them out, we provided kind of classic lab instructions and asked people to re-sketch and see what they actually needed to know about each step. So that was a really interesting and useful time for us to just give it to someone else and see what they thought. So then we did, again, lots of trying things out, taking them down to the clinic, making fake codes and trying to test the acceptability of that with users. And just playing a lot with pricking our own fingers and asking people to try it out and follow different videos that we'd made. So this is us trying to show someone how to do the finger prick sample on the phone, on the website. So when we asked people to do that and asked to watch them do that, it was clearly obvious that you need 2 hands to do the blood test, and you can't be scrolling up your phone to see what to do next. So that's something that we thought, well, that's rubbish. So we created a nice video, and we text the link out on dispatch of the kit and hope that people watch it prior to receiving their kit, but also have a reminder of the bit.ly link to access the video when the kit's sent out on the printed instructions, which is you can lay out in front of you and not have to shuffle around when you're trying to do the kit. I also spent some time with Kingston University students, and I watched 25 people try and do it and just got loads of interesting insights there. So one assumption we had was someone else can help you do it. So watching 2 people try and do the test together was a mess. It was terrible. It was not a helpful tip to provide. They more tried to make it a competition rather than tried to do it right. When you try and rush this, it doesn't work. Interesting things like the first step being go and wash your hands. People are like, oh, I'm already clean, so they wouldn't bother. And it wasn't the point to go and wash your hands to be clean. It was to make your hands warm, but they hadn't got that far in the point, so they thought, I don't need to do that, so I won't do it. So it's about bringing the justification up top and then giving the instruction afterwards. I think I'll move on because that's just, I think we've had enough of that one. So then we defined what we thought our MVP user journey step-by-step experience could be, and did some nice graphics so we could help communicate it to the council. So someone can order a STI kit online, they're notified when the kit's been dispatched, and with that blood test link video on it, they receive it by post, so nice and quick. And they can do the kit as soon as they want to, post it back for free, and then we can see that results are within a week. And that's something that we've really tried to kind of encourage people to understand, that this is something you can achieve within a week, and you don't have to book time off and wait 2 weeks once you've made the effort to go to clinic. And then at this point we're referring back into a clinic if there's a positive result for treatment. But more recently, well, very soon we're about to launch our chlamydia treatment service that we can offer within the results message to be sent out in the post, which is cool. So that might be a branching journey at that point. So this was the kind of MVP front end that we've pretty much stuck with, actually. At the beginning we did have for Southwark and Lambeth, and now we don't have to say that anymore because we're commissioned elsewhere, which is brilliant. And just to highlight, that we did ensure that it was nice and friendly for a mobile phone, all those things that you can appreciate. So that was the kind of user-facing work. And just to go back quickly to the fact that we have a whole other set of users being the clinicians, and clinicians that have lots of other things to be doing, and to make sure that the admin interface that they have to interact with was really fitting in with their workflow and didn't provide a whole lot of problems, and actually provided a easy way of them to track the user. So the difference here being really that sorry, I keep thinking my arrow works. That when someone turns up to clinic with that text message to get treatment, they've got a code that they can show a reception team member, and they can be fast-tracked, and that can really easily be logged back into the SH24 admin system. We didn't try and mess around with interfacing with existing clinical record systems, because no. And the one that they can use for us is something that is accessible in a web browser, but you just have to log in two-factor authentication. So you get a code sent to your phone, and you're able to very quickly locate the user that's turned up and tick that they've attended clinic, and add notes if you need to. There's lots of work we've done on creating different layers of permissions for the admin interface. So, for example, we're developing a layer now for commissioners, so they can't see any personal information about any of our users, but they can see all the data for the usage in their commissioned area. Some clinicians are assigned to more than one clinic if they share the jobs. Some have to be defined just to one clinic or to one region, and all that can be controlled by us. So this is like a really early version of the admin interface. So this would be where the list of orders are displayed, and any of these flags mean that you have to do something about it. So if you've got a safeguarding flag, that means one of the questions that someone's answered within the order form needs your attention, that you need to provide that person with some support. So especially if they're under 18, we've got lots of policies and protocols that the clinical staff have to follow and make sure that they're offering the right support. And those flags can be removed once being kind of dealt with. Not that I wouldn't say those words, but yes. So this is the kind of statuses of an order. So created, packaged, dispatched, received at lab. So at this point, we're notified when a kit is received at the lab automatically, and that will prompt a text to the user just to reassure them that it has arrived safely. This is that results come to us, and then this is that we've notified the user of their result. If that hasn't been flagged after a certain amount of time, we've got another responsibility to encourage that person to go and receive the treatment that they need. Okay. So after launch, so we launched the STI testing service in March 2015, and we've had over 40,000 orders now, which is really exciting, and some great feedback from our users. So where we're at now, this is where we started, Little Southwark and Lambeth, and now we're commissioned in to provide STI testing in Essex, bits of Kent, Herefordshire, and up here as well. Not sure if you call that the Midlands or not. Anybody? That area. And there's loads of opportunities for us to work with other areas as well. So it's a bit of a strange commissioning world. So you kind of have to wait for a tender to appear and work really hard to get it. So this is a design squiggle. I'm sure you've heard of that before. But just this is an illustration that we have put up in the Design Museum, having been nominated for a Design of the Year award last year, which is really, really exciting for us. So just some stats that we had to provide. So our users are rating us 4.94 out of 5, which I think is bloody brilliant. Chris thinks it's not good enough, so we've still got lots to do. 81% of our users order on mobile devices, so that's useful to know and just reinforces our need to be designing mobile first and doing good QA. 98% of the results are sent within 24 hours, which is way faster than a lot of services. Yeah. So this is kind of opportunity, so we started this all discovery work, and then we had lots of things happening, including launching in new areas, and I'll talk about some of those optimization points in a minute. But really quickly, so MVP2 was around support, and I mentioned about telephone support, and that was the kind of concept. And after a lot of, actually, because we'd launched a service, we were understanding user behaviour already, so we didn't have to do a whole lot to understand how people wanted and were trying to interact with us. So we offered talk to us by text, so opening our portal for people to just get in touch with us and ask us questions and allow the clinicians to respond. So we've now got 3 nurses that we've hired to work on the admin side. And they can also text, call back and receive a call from the clinician to discuss whatever it might be. On top of the kind of discussion support, there's loads of information that we added to the site as well. So a whole chunk on, these are the STIs that we offer testing for, but all information about all the others according to your gender as well, and what the tests are like, what it means long term, what the side effects and symptoms are, side effects of treatment, and where to access services and specialist support for each of those. And on top of information about STIs and infections, we added information more generally about sexual health. So I think we've got it here, yeah. So cervical screening and erectile dysfunction being quite a high, what's it called when you get loads of clicks? That. Fertility, lots of different kind of topics that might come up usually in a clinic conversation. And then the third MVP being about contraceptive services. So first, before we started creating order journeys, we created information pages for each of the 15 different types of contraception available on the NHS. And some of those pages get 2,000 views a day, which is amazing. And now we found out yesterday that the BBC point to those pages on any stories about contraception, which is really super exciting. And again, just did lots of focus groups with lots of people just to get insight on what it is that they understand and what it is they really don't understand, and what helps make a decision around what contraception choices people are making. So the main navigation, we've got options for emergency contraception, those that protect against STIs, those that are taken daily, those that are long-lasting, and using those as kind of toggles or filters for decision making. And then more recently, we've just launched this month the contraception ordering service online. So that's for the progesterone-only pill and the combined pill. And that's been a long process with lawyers, basically. So we worked really hard with clinicians and got our order forms kind of peer-reviewed by 8 local GPs, and did a lot of work on that kind of clinical front to ensure that the order form was doing what it needed to do, and kind of mapped really robustly what would be done in a physical service. But just getting the sign-off and insurance from lawyers took almost a year, but we're there, so we've done it. And we're the first free online contraception service in the UK. So there's our little blog today. You can read it. And then chlamydia treatment is happening very, very soon, which is great. This is a little mock-up, that's actually paracetamol. The actual tablets are massive, so this is a little bit less intimidating for a mock-up. And we work with a partner pharmacy to deliver the prescription. So how that works really quickly is that, as with the SH24 STI order, someone logs on, completes an order form, and with the kind of more medication side, a doctor instead of our nurse team, the doctor has to review everything. And if there are any indications that there's a risk or there's something that doesn't quite work, there's a contraindication, then the user will get a phone call from that registered doctor, have a phone call before any prescription is made. And if they deem it unsafe, they'll be given information about how to access other services. So once the prescription is generated, it can be accessed again through our admin system by the pharmacy. You can download and print off the prescriptions and dispense them from there. So we've had to actually fight as well to get them to use nice boxes and nice envelopes, because that's not standard for that service. So even down to that detail, having to visit the pharmacy and tell them what boxes to use, we're keen on getting that right. So optimizations. This is, I think, my last slide. So yes. Where do I? So we're very aware that we delivered the service within MVPs. So there's so much that we could do. So it's how do we manage that backlog of ideas and of things that we want to use to bring a better service to the user group. And most of that we focused on the clinician side in terms of optimization. So in terms of users, we reshot the instructional videos, but it's still a massive struggle to get people to click on that link and get them to watch it. We know that about, I think it's 20 or 25% watch the video. So that means a lot of people aren't watching the video. And our research shows that people achieve the blood test 10 times easier, 10 times faster if they watch the video. And it's a very short video, it's quite a nice video, but people don't watch it. So there's still a struggle there and still a lot of work that we could be doing to try and figure that out.
Do you
yes.
In the communication that's alongside the video, do you say that?
Probably we need to do that a bit more explicitly. We provide a top tips slip that goes with the blood test now, and the top one is, you'll find this easier if you watch the video. But I definitely think there's a need to put in, you know, Dave says it's easier if you do the video rather than we say. But we're redesigning the instructions over the next few months, which is cool. So yes, more ideas is good. So we introduced a click and collect option, so people can order the STI kit online, and instead of having it delivered to their home address, go pick it up at a clinic. And we found that people weren't picking them up, which is really annoying. So we sent a reminder text message, and the pickup rate is now up by 40%, which is good, but still not fantastic. So again, there's more comms work we need to do around why do you really want to collect it. It's quite easy to get it posted home. It's not costing you anything. It's discreet, it'll fit through your letterbox and all that kind of thing, just to reinforce the message of what is actually convenient at the time they make the order. Customer conversation view. So yeah, happy clinicians. So the clinicians that work on the admin side are able to basically view orders that have come through from multiple orders by the same person. All the conversations is listed as one rather than per order, which is a nice optimization for the clinicians. Less clicking forward and back. Selective testing, so people can opt out of testing for HIV and syphilis if they don't want to do that, which means happy providers, not paying for tests that people don't want to do. Flags, so adding to the example I showed earlier in the admin system of a safeguarding flag, but more around timed and automation of things, more flags. Auditing, so happy commissioners, they're able to see who's logged into our system and what they've done when they've done it. So if there's a reason that they need to backtrack and say who did this, why, then there's really clear auditing without having to come to us and ask us, they can find it themselves. Invoicing, happy marks, so there's a lot of nuance in the invoicing, so when a kit is sent out versus when it's come back, and what pathology was actually done versus what the kit was sent out, any delays with anything. So there's lots of things that have to be figured out, and Mark spends too long doing that, so we're developing that, which is happy. And service quotas and daily capping. Happy commissioners, very unhappy service users. So for a lot of our areas now, we have to limit the amount of kits available per day because we're overperforming, which means too many people wanted to use a service, which is not okay for commissioners. So we are not able to do any kind of advertising or anything, and can't really talk about going into GPs and putting a poster up because it's too much. So not so happy service users. We'll have to see what April brings because that's a new financial year, and who knows. So they're just some of the things we're trying to do to add to our service offer, but you can see there's quite a lot of different mouths to feed, smiles to try and achieve. So yeah, I'll stop there. Thank you, everyone.